Okay, this video is on structure and your approach in terms of structure for the CCT exam. It is intended to provide you with a framework for going through a general consultation. However, it should be mentioned that you should also remain very flexible in your approach to the CCT exam, and having a rigid structure is not appropriate either. However, at the beginning, when you're starting off practicing, it can be very useful to have a structure to apply to your consultations. I should also reiterate that this is in no way an official guide for the CCT exam and should only be viewed as supplementary material to your own exam preparations. So the assessment is broken up into three areas. The first area is history and examination, first half of the consultation, or the first 5 minutes. Then you go into the second area of assessment, which is the second 5 minutes, and that is your clinical management skills. And then there's the third area, which is a little bit more nebulous, and this is the attitude and communication skills section of the assessment. It deals with things such as empathy, patient concerns, non-verbal communication, cues, and patient understanding, along with you remaining flexible in the plan and follow-up activities. So what we're going to do now is just run through how a step-by-step consultation might work in terms of structure, with a very clear first half and second half to the consultation, which allows you to be aware of time as well. You start off when you hear the bell. The patient will enter with the examiner following them. Stand up and introduce yourself to the patient. A handshake and a smile are almost always appropriate, and sit down. Offer to the patient that they are very welcome, and you can start with an opening line. Something like, "How can I help you today?" is very appropriate. You then sit there and listen for what's called the golden minute. You allow the patient to talk until they stop, and that is really important because it allows the patient to get a lot of their agenda out on the table. Now, there may be other things to go through in the history, but it's really important that you don't interrupt the patient during this period. Once the patient has stopped talking, you can enter your series of open and closed questions, and you've entered the history-taking section of the consultation. Often people find it useful to apply a mnemonic when further exploring a presenting complaint. Something like Socrates is a well-known one to most medical students. It's very important also, when you're taking the history, to pick up on any cues, or verbal or non-verbal, from the patient, and address them at the time. Even if you don't go through them in full, it's important to acknowledge that the patient has given you a cue and that you will come back to address it later. Also important not to miss out on any red flags. For example, if the patient is coming in with a headache, don't miss the fact that it is a thunderclap headache, that it's 10 out of 10, and that they've got neck stiffness and some other neurological symptoms. Then it's appropriate to ask the patient about any past medical history they might have, any medications they're on, and any family history they might have that might be relevant to the presenting complaint. Then it's appropriate to ask the patient about their social history and the impact that these symptoms have had on their activities of daily living. Has this affected their job? Has this affected their family life or home life? And it may be appropriate to ask this, at this point, whether the patient takes any alcohol or smokes any cigarettes. It's also important to check if the symptoms have had any impact on the patient's mood or had any psychological impact on them. Is this affecting your mood? Might be an appropriate question. And some follow-up questions along the lines of sleep and psychiatric history might be appropriate as well. It's then appropriate to explore, if the patient hasn't already given it to you, what their own agenda might be. So, what do they understand about their symptoms? Have they any concerns or worries about what's going on? And what were they hoping you could do about it? This is ideas, concerns, and expectations, or ICE, and it's so fundamental to what we do in general practice that it's important to get these out on the table early. It's then appropriate, once you've got the history, got the biopsychosocial element of the history, and also got the ideas, concerns, and expectations out on the table, to summarize what you found. So state what the patient has come in with, state what they're worried about, and what impact it's having on their lives, and then also explain that you're going to conduct an appropriate examination now, and take things from there. So offer out loud that you would like to examine the patient and what systems you'd like to examine, along with any vital signs or body mass index you'd like to check. The next thing that you will do, this is, I suppose, represents the end of the first half of the consultation. The second half of the consultation then begins with you explaining your findings from history and examination and what you think the likely diagnosis is. Explain this in non-medical terms or non-medical jargon. Allow the patient time to absorb what you said, and allow them time to ask any questions they might have. It may also be appropriate to address at this point any ideas, concerns and expectations they may have expressed in the first half of the consultation. So while you ask the questions about ICE in the first half, you're now addressing ICE in the second half in the explanation section. Address any health beliefs they might have, any concerns they might have about their care going forwards. Offer a shared management plan based on what you found in history examination, and one that's appropriate for this patient. Once you've come to a shared understanding of what the management plan is going to be, offer appropriate safety netting, what symptoms the patient should look out for, when they can expect to improve, any side effects of any medications that they might experience, and things to look out for. Then you can offer any follow-up if it's appropriate, and make sure to offer any written information as well if it's appropriate. Check the patient's understanding of the management plan and follow-up, and if you still have time, close the session appropriately and wait for the bell. It's really important when we talk about structure that we don't get lost too much in a tick box system. While it's really good to have a framework to hang your questions on, you also don't want to get hung up on it too much. There should be a flow to your line of questioning. Each question should flow appropriately from the last, and it shouldn't be disjointed. So, you know, this is a conversation between two equals. This is not you going through a tick box system, just going through the motions, and the examiner will pick up on it if it comes across like that.